Assalamu alaikum wa rahmatullahi wa barakatuh. In this video, we will discuss the group of diseases called amyloidosis, a lecture made by Professor Dr. Manal Salman, presented by me, Heba Ahmed, lecturer of pathology at Pathology Department at Shams University. And after the end of this lecture, you should be able to define amyloidosis and classify its types, to recognize the composition of amyloidosis according to different types, explain the pathogenesis of different types of amyloidosis, and to describe the pathological features of amyloidosis of different organs, and finally to recognize the clinical features and list the methods of diagnosis of amyloidosis. First, I want to talk about protein synthesis. To start with, let's know that protein synthesized in the cells in the form of chain of amino acids, okay? These amino acids then accumulate to form connected to each other to form a chain, okay? This chain is folded in certain type, in a certain shape, to form a protein molecule. The shape of the protein determine its function, determine its role in the cell. When the protein is misfolded, this protein cannot do its function. Proteins act as hormones, act as receptors. These proteins must be arranged in certain shape. After formation of the chain of amino acids, they are folded in certain shape, three-dimensional shape. When this folding is interrupted due to any cause, the protein cannot do its function and it must be degraded, and the degraded amino acids will be reused to form new proteins. Okay, how this protein is degraded? When the misfolded protein present intracellular, a molecule called the proteasome degrade the misfolded protein. It contains proteolytic enzymes which degrade the misfolded protein. When the accumulated misfolded protein present extracellular, these proteins are taken and degraded by macrophages. If there is a defect in degradation of protein, these proteins accumulate in extracellular component. These misfolded proteins are insoluble, and so they are unstable. They tend to aggregate and attach to each other and form larger molecules. This accumulated misfolded protein is called amyloidosis. Let's explain the issue in this figure. This is a misfolded protein. This is a naive protein synthesized from a chain of amino acids newly synthesized, and this is a misfolded one. Okay, the misfolded protein is unstable, so it tends to attach to other misfolded proteins. They form soluble oligomers, a molecule formed of few number of misfolded proteins. Then these oligomers attach to each other to form a larger molecule called the protofibrils. These protofibrils further accumulate to form the fibrils. Okay, these accumulated fibrils are the structure of amyloidosis, which is the physical appearance. The misfolded protein may vary according to the type of amyloidosis. Amyloidosis is a group of diseases, not only one disease. The misfolded protein itself may be different, but the arrangement of the misfolded protein finally take the physical appearance of the fibrils, which are further the fibrils are further arranged in what's called beta-pleated sheath. It will be discussed later. So when we talk about amyloidosis, we want to know, as we said, it is a group of diseases related to accumulation of misfolded protein. Each type of amyloidosis, we have to know what happens, okay, and why it happens, what type of protein accumulate and why it accumulate, where does the misfolded protein accumulate, and what is the effect of this accumulation. The definition of amyloidosis answer These questions, it said that amyloidosis is extracellular deposition. Where is here the extracellular deposition of what? Of amyloid material. Why? Why is according to the cause, and it will be discussed soon. Where in different tissue under certain pathological conditions, this is the why, and it will be discussed, leading to the effect, which is tissue damage and functional compression. Okay. These abnormal fibrils, as we explained, are produced from aggregation of insoluble misfolded proteins. Normally, in the normal folded state, they are soluble, but when they are misfolded, they are insoluble. What is amyloid material? Amyloid material, chemical composition of amyloid material vary according to the disease, while physical arrangement is the same in each disease. The composition of amyloid material widely vary, and the most common are amyloid associated protein and amyloid light chain protein. So they share the same physical features nature, but they are different in chemical composition. This is the appearance of the beta bleated sheath. It like زي ما بنقول في العربي ان هي حاجه بليسيه، يعني حاجه مكسره فيها كسر. This is the appearance of beta bleated sheath. It means that there is repeated angles, as we see in this figure. The fibrils of protein arrange in chains formed of 4 or 6 fibers. These fibrils stained by Congo red stain. This is a stain we used to highlight the amyloid protein. It appears under the H and E stained slides as salmon red. By a polarized light, it gives a green apple green pyrefringence. This is the most characteristic for amyloidosis. Under the microscope, it appears like fibrils at the picture number C. Regarding chemical composition of amyloid protein, it composed mainly from fibrillary proteins. Fibrillary proteins have many types. Two major types are amyloid light chain protein, which is produced by plasma cells. This is the light chain is part of the antibody. Antibody is formed of heavy chain and two heavy chains and two light chain. In amyloidosis, the accumulated part is amyloid light chain. The second most common type is the amyloid associated protein, which is derived from a precursor called serum amyloid associated protein. This protein is synthesized in the liver in inflammatory conditions, and when it increased, the product of which is the product of degradation, which is called amyloid associated, accumulate and form the reactive type of amyloidosis. Other types include beta amyloid, which accumulate in cerebral lesions of Alzheimer's disease, and beta 2 microglobulins. These microglobulins do not cross the dialysis membrane, and they accumulate in the blood of patients on hemodialysis. It accumulates in joints and cause carpal tunnel syndrome and other joint lesions. Another protein cause amyloidosis called procalcitonin. This protein accumulate in cases of medullary carcinoma, cause amyloid in thyroid especially. Another component is beta component, which is a component circulating in plasma, and it lead to it aid in the formation and connection between parts of amyloid protein. Finally, the proteoglycans and the glycoaminoglycans, the last component of the amyloid protein. So these are the three major components. Mainly the fibrillary protein and the P component and the proteoglycans aid in the adherence between its misfolded. Now we will move to the pathogenesis to answer the question why. Why this protein accumulate? Proteins accumulate in amyloidosis are either normal proteins which have inherited tendency to be misfolded. So when they accumulate in large amount, they disfold and they form amyloid. while others are due to mutated protein which has the tendency to which is misfolded and so form amyloid. So it is either a normal one with inherited tendency to misfold or a mutant one which is already disfolded. In multiple myeloma and plasma cell dyscrasia, the proliferated plasma cells secrete excessive amount of Ig protein. The light chain component has tendency to misfold and accumulate in the form of amyloidosis. And this doesn't occur in all patients of amyloidosis or plasma cell dyscrasia, but in small number of them. But this category compose the most common cause of amyloidosis. However, not all of them will develop amyloidosis. The second type, or the second example, is the synthesis of serum-associated amyloid-associated protein. This protein secreted under conditions of inflammation where there is excess stimulation of immune system by interleukin 1. This protein is synthesized in certain circumstances or certain patients with a defect in degradation. Associated amyloid protein is produced and accumulate. Classification of amyloidosis. Amyloidosis has many types of classification. It may be classified according to the composition of the amyloid protein. It is further classified according to the distribution of the amyloid protein. For example, amyloid light chain protein may accumulate diffusely in the body and may accumulate in certain area. So it may cause systemic amyloidosis or localized amyloidosis. Here we are with systemic amyloidosis. The most common type is the primary amyloidosis. This is referred to the type related to beta cell or plasma cell dyscrasia, which means proliferation with dysfunction, increased excessive secretion of immunoglobulins. The amyloid light chain protein, the immunoglobulin light chain, accumulate. It is secreted in urine, which is called Pathogenic protein in urine and in serum. This not happens only with multiple myeloma, but it may occur also with proliferated plasma cells with dysfunction, with excessive secretion of immunoglobulin without definite mass formation. So it is not called multiple myeloma, and this is more common than multiple myeloma itself. Sites of deposition. The most common sites of deposition of amyloid material is the kidney, the liver, and the spleen. Also the GIT, the heart, the respiratory system, the peripheral nerves, and in skin and tongue. And the sites which are easier to be biopsied are the sites where from we take the biopsy to diagnose amyloidosis, because the clinical picture, as we will discuss later, is subtle and it may not be specific, and it can't be diagnosed except by morphological recognition by biopsy and using of special stains. These are the plasma cells. They have eccentric nucleus with cartwheel appearance of chromatin and basophilic cytoplasm. This is the composition of the immunoglobulin. It is composed of two heavy chains. They have the Y-shaped appearance, and the two light chains that appear in green. These light chains, when present in excess, they form the amyloid material seen in multiple myeloma and in plasma cells dyscrasia. Secondary amyloidosis, which is now preferred to be called also reactive amyloidosis. This amyloidosis occurs due to accumulation of amyloid-associated protein. As we said, it is due to derived from a precursor called serum-associated amyloid protein synthesized in liver in chronic inflammatory conditions due to excessive stimulation by interleukin 1. The chronic inflammatory conditions which associated with this type of amyloidosis before were the types of infections related to bacterial infections like TB, bronchiectasis, chronic osteomyelitis, and chronic skin infections, By further development of antibiotics and lines of treatment, these causes become less common, and the more common causes becomes rheumatoid arthritis, inflammatory bowel disease. Moreover, this type may occur with certain tumors like Hodgkin lymphoma and renal cell carcinoma. The most common sites of deposition are kidney, liver, spleen, lymph node, and adrenal glands. The hemodialysis associated protein amyloidosis due to accumulation of beta-2 microglobulin. This beta-2 microglobulin accumulate in this group of patients because it can't cross the infiltration membrane of hemodialysis machine. It first accumulate in the wrist, lead to carpal tunnel syndrome and compression of medial nerve. Later, it accumulate in different joints and lead to loss of their pathological features of amyloidosis. Amyloid protein accumulate in different organs. First, accumulated amyloid doesn't change the size of the organ, but later on it may lead to marked enlargement according to the severity and the progression of the disease. Heavy deposition of amyloid appear waxy and gray. It leads to increased firmness of the consistency of the organ. It changes from the soft consistency to a more rubbery, waxy consistency. The amyloid material stained by iodine, giving the mahogany brown color. And that is the cause of the misnomer amyloidosis, which means accumulation of a starch-like material in tissues. Amyloid means starch because they share the same staining criteria with iodine. But now it is clarified that amyloid composition is mainly of proteins. Microscopic appearance of amyloid. Amyloid appear as amorphous, pink, acellular, eosinophilic material. It accumulate in extracellular area in vascular walls. It starts as small aggregate, and with progression of the disease, it large in size and lead to compression of surrounding parenchymatous part of the organ, and leading to atrophy, loss, replacement, and subsequent loss of function. By congruent stain, the amyloid material appear salmon pink in color, and this is not specific for amyloid. The more specific and the more diagnostic is the use of congruent stain under examination of it under polarized light microscope. It will give the apple green pyrefringence characteristic appearance of the amyloid. It also can be highlighted by immunofluorescent stains. Okay. By electron microscope, the amyloid appear as non-branching thin fibrils, as have been showed in previous slides, formed of beta-pleated sheet of a chain of misfolded protein wound together. This is a section in amyloidosis of the kidney. In this example, amyloid in kidney first accumulate in the wall of glomerular capillaries, appear as increase in mesangial material. By progression, there is variable thickness of capillary membranes, lead to subsequent compression of the capillaries with loss of their alumina, and further replacement of the glomerulus totally by the amyloid material. Amyloid material also may precipitate around them in the interstitium and surrounding blood vessel. Here is the appearance under the polarized light. The apple green pyrefringence appear in the wall of blood vessels and inside the sclerosed glomeruli. And the glomeruli totally replaced by amyloidosis. Here is the appearance of amyloidosis by electron microscopy. It appears as fibrils running in different directions. The amorphous pink material under the light electron microscope appear as these accumulated lines. These are the protein fibrils accumulated in the beta-pleated sheet appearance. Amyloid amyloid protein can precipitate in any site. The most common sites are the liver, kidney, and spleen. It also accumulates in the heart, in the GIT, skin, and etc. Amyloidosis in the liver accumulate first in the space of this. Space of this is the space between the endothelium lining the sinusoidal spaces of blood run between each cord of hepatocyte. Amyloid first accumulate in this space between the lining of the sinusoids and the hepatocytes. By progression of the disease, these accumulated amyloid enlarge in size and lead to compression and atrophy of the corresponding hepatocytes. By time, the accumulated cords, branching cords of amyloid coalesce and form a large homogeneous pink area formed of aggregated cords of amyloid, like this picture. In this picture, a diffuse area of liver cords replaced by wide cords or wide ribbons of anastomosic branching wide ribbons of amyloidosis, which has accumulated and progressively compressed and lead to atrophy of corresponding hepatocytes. Another light microscope picture show the replacement of hepatocytes by the eosinophilic ribbons of amyloidosis. This is the gross appearance of amyloidosis in liver. This liver had enlarged and it has waxy consistency. The borders are sharp. It is like if you are having a section in a rubber. It is waxy. It is flat cut surface, sharp borders. The waxy material appears in light brown appearance. It can be seen as a mesh of light brown material in the background. By light microscope, by Congo red stain under the light microscope, the amyloid material appear salmon pink in color. The salmon pink in color under polarized light gives the apple green birefringence. Amyloidosis of the kidney in this picture, the amyloid has been deposited around the capillaries of glomerulus and around the blood vessel in between the two glomeruli in C. We can see this material when accumulate, it lead to compression of the capillaries and total replacement of the glomerulus by the amyloidosis. This is the appearance of amyloidosis of the kidney by H&E, and by Congo red under the polarized light, it gives the green, light green, apple green, birefringence. This is the apple green birefringence, the green foci here and here. Okay. Accumulation in spleen take one of the two forms. Spleen is composed of a white matter and red bulb. The white matter composed of lymphoid follicles and surrounded by the red bulb. Amyloidosis for unknown reasons either accumulate in the red bulb or the white bulb. If the amyloidosis accumulate in the white bulb, it gives appearance or beaded appearance like seeds or like بتتشبه بحاجة من الحبوب اسمها sago beans. So it is called sago spleen. The cut section show granules of accumulated amyloid in the white follicle. While this is the microscope appearance, the microscopic appearance. Here is the amyloid accumulated inside the follicle. Okay. I can't draw the line irregular, but here it is. Okay. This is a lower power view showing multiple lesions, and that is why it is called sago spleen. Sago referred to type of beans. The name was given by the one who described this lesion. When the amyloid accumulate in the red bulb, it is more diffuse and it is called diffuse amyloidosis of the spleen. The spleen becomes enlarged. As we said before, the consistency become harder, the surface become flat, the borders are sharp, and it is more dark in color, more heavy in weight, more waxy in consistency. The effect of amyloidosis lead to the appearance of the clinical picture. It depends according to the affected organ. Amyloidosis clinical picture may be non-specific in the form of weight loss or other non-specific symptoms, but specific symptoms develop when there is affection of a parenchymatous organ with consequent loss أو يعني major or apparent loss of function. The most serious is the affection of the kidney. The amyloid lead to protein loss up to the nephrotic syndrome development and subsequent renal failure. It can be diagnosed in renal biopsy, when a biopsy taken from a patient with disturbed renal function and nephrotic syndrome. The amyloid may be highlighted in the renal tissue and hence diagnosed. Affection of liver and spleen may run insignificant. Cardiac affection. Amyloidosis of heart occur most commonly in senile patients. It may be a part of systemic affection, or it may be cardiac affection, especially cardiac affection when it's called senile cardiac amyloidosis. Accumulation of amyloid in heart may be accumulated within the myocardial fibers, or it may accumulate under the endocardium. When it accumulates under the endocardium, this accumulated material interfere with the conduction system, lead to development of cardiac arrhythmias, may lead to death. Accumulation within the myocardial fibers lead to cardiomyopathy, especially restrictive type of cardiomyopathy, which may lead to defect in cardiac function. GIT deposition of amyloid lead to malabsorption. A localized deposition of amyloid in tongue may cause a mass and may cause clinically macroglossia. Cerebral accumulation of beta amyloid lead to development of Alzheimer's disease, and it is seen in the plaques of Alzheimer's disease. Accumulation of beta 2 microglobulins in patients of dialysis lead to the development of carpal tunnel syndrome. So as we see, manifestations could be non-specific and could be according to the site of deposition. This is also differ according to the type of the material deposited, okay? Because in beta 2 microglobulin it accumulate in joints, beta amyloid accumulate in Alzheimer and brain, and etc. Diagnosis of amyloid is mainly by morphological recognition. So biopsy taken to highlight the amyloid and examine it under light microscope or electron microscope using special stain, congruent, biopsy is taken from gingiva or rectal mucosa. These are sites which could be easily accessed. It could be taken also from abdominal fat. Biopsy from kidney taken when there's affection of the kidney. Prognosis of amyloidosis. Amyloidosis prognosis is worse in the systemic affection. And in systemic affection, the primary causes of amyloidosis is much more poor in prognosis than the reactive type associated with inflammation. Amyloidosis may lead to renal failure, cardiac arrhythmias. In reactive amyloidosis, the treatment of the associated condition, inflammatory condition, and control of the interleukin-1 secretion and the release of serum-associated amyloid protein lead to stopping of the progression, and it may lead to resorption of the amyloid deposits. The worst prognosis is with multiple myeloma, and local types of amyloidosis had better prognosis. To sum up the lecture, amyloidosis is extracellular deposition of insoluble fibrillary waxy proteinaceous material. As we said, it is accumulated due to misfolding of protein with defect in clearance. Two main types are primary and secondary, which is also called reactive amyloidosis. It could be localized or systemic, compromise the blood supply, and lead to subsequent pressure atrophy of organs and tissues. Renal amyloidosis is the most serious and important cause of morbidity, leading to nephrotic syndrome and renal failure and even death. Now please you can stop your video and try to answer the matching to examine your understanding. I hope you have understand the lesson. بالتوفيق إن شاء الله. السلام عليكم ورحمة الله وبركاته. The answers are highlighted in red color. Thank you.